care. I'll try to simplify the things and as much as possible. One thing is very clear when we talk about acute COVID issues during acute pandemic, we don't have much intensive care issues, especially respiratory one. But of course, whosoever lands up in intensive care, they do have some component of MISC, despite their MISC, despite their the COVID RT-PCR positive. We all know a lot about MISC. So my presentation will be just restricted to the intensive care, what actual issues we face as an intensivist. So my aim is very clear. I'm going to talk about acute COVID ICU issues, some issues related with the MISC, only ICU related issues. And of course, when we talk about ICU, it's mainly complications we talk about. We all know that there are various spectrum which we see in intensive care. The problem during patient who is suffering from acute COVID, that is RT-PCR positive, you don't get good intensive care. You don't, it's always a little bit compromised. You don't have ultrasound, you don't have manpower to tackle those patients in, you can say, temporary made intensive care as compared to an MISC's RT-PCR positive. So still we get a lot of issues related with the patients usually present with hypotension, cardiac involvement. You give IVIG, steroid, and most of time they are uneventful. Recovery is uneventful. Second is you give IVIG steroid to these patients, but they require organ support. They require toxin removal by 3RRT, and you need to give repeat IVIG. Same way, at times, patient just present with the organ dysfunction, and you require therapies like ECMO, mechanical ventilation, CRRT. And of course, as I told you, when these patients are suffering from acute pneumonia without MISC, most of the time they don't need mechanical ventilation. They are not very critical. They just got okay by simple management and time, just steroid, and you need not give drugs like remdesivir. Let's start with the cases. This is a 12-year-old child who presented last year with fever for 4 or 5 days, respiratory distress for 1 day, though RT-PCR there was negative. In our emergency itself, RT-PCR came positive. When patient came to us, he was quite hypoxic. Saturation was 70. And you can see the PaO2 is 41 here. After giving BiPAP, the saturation become 98. The beauty of pediatric patient, pediatric acute COVID pneumonia is that response to therapy. Look at the chest X-ray, you can see bilateral infiltrate. More than just ground glassing. That's a little bit difference between, adult and pediatric. In pediatric patient, you may not get classical ground glassing always, but you can have various sort of pneumonias and various atypical pneumonias. This is a CT scan. You can view this is more than just ground glassing, as you cannot view the vessels inside. So it is just not ground glassing. It is a uniform sort of consolidation. What are the issues we face in these patients? What are the indications of CT chest in pediatric? We don't do CT chest even in adult, unless we find some complication related with acute COVID where hypoxemia is not improving despite of giving everything, or if you're thinking of some other differential diagnosis. Or after 7 or 8 days, somebody is having problem like persistence of fever and RT-PCR time has gone away for 7 days when likely it is going to be positive. For diagnosis, you may rare circumstances, you may get CT chest in pediatric. Regarding ventilator setting, it has to be optimal. You start with non-invasive. Don't go for invasive ventilation to start with, because invasive ventilation is difficult in acute COVID pneumonia. Keep everything moderate, like optimum PEEP. Just try to keep minimum PEEP and may require to give a little bit high oxygen. So it is a condition where you give high oxygen and low PEEP setting. As I told you, NIV is preferable over invasive, and you can try conscious prone ventilation. You just apply BiPAP or just apply HFNC and make the child prone. That is much better than invasive ventilation. Even if you land up in invasive ventilation, outcome is much better as compared to adult population. Drugs, of course, you are going to give steroid if there is a significant pneumonia. Remdesivir and anticoagulant is just doubtful. Nobody knows the role of remdesivir, but we usually give a patient of acute pneumonia with COVID RT-PCR positive, we give remdesivir even if patient is not immunocompromised. Regarding course of this patient, as I told you, RT-PCR came positive here. Total leukocyte count was 6,500. Child was big enough, so this patient could get better in adult ward, adult ICU. And CRP was high, antibodies was negative, D-dimer was high. We gave remdesivir, methylprednisolone. We started with enoxaparin, and the outcome was perfect. The patient was discharged after 10 days. So the beauty of pediatric COVID, despite of sick disease, despite of severity of disease is too high, these patients show very good outcome. Not always, but most of the time. Now look at this is an unfortunate baby, a 4-month-old with a respiratory failure. He had fever since past 10 days. Cough past, patient was having cough for past last 6 days. There was an increase in respiratory distress. There were deranged liver function, elevated ferritin, CRP was pretty high, D-dimer, LDH was high, hemogram showed anemia with leukopenia, chest X-ray showed bilateral infiltrate. I'm going to show you in the next ray. Patient desaturated when came, 70% saturation was there, required intubation. This patient required ventilator support for 1 month, and in fact, more than 1 month. Various infection patient acquired, and ultimately the patient was lost. And look at these are the various chest X-ray, and this was a chest X-ray done before we lost this child. And you can imagine the patient not only had an acute COVID RT-PCR, but all the signs and symptoms of MISC. The ferritin was pretty high. There was a leukopenia. So ultimately, this patient has HLH also. So in less than 2 years, what we learned the lesson, you should rule out severe combined immunodeficiency and congenital HLH. In this patient, it was severe combined immunodeficiency, but congenital HLH, if you encounter a patient who is infant or less than 2 years, with severe, with critical respiratory involvement secondary to COVID, always think of HLH and SCID. Look at another child, 8-year-old, who presented to an emergency with lot of body weight, intense body weight. In fact, this patient called me online that everybody in the family is RT-PCR positive and this child is having intense body ache. Patient also had high-grade fever, 100, 300 for past 5 days. She was not able to move at all, not accepting orally. And he sent me the photo, he shared me these photos that patient has developed swelling all over body, especially on the dorsum of foot and the palm. This patient, I could diagnose on phone that probably she's having acute COVID, but there must be some component of MISC. So in this patient was admitted, and the issues here is, should we give remdesivir to this patient where there is no respiratory involvement? Probably there is no need. When to give steroid? Of course, whenever we are looking at these type of patients with MISC with hyperinflammatory signs, we should give steroid, and patient become fine after giving steroid, didn't show too much improvement, but required IVIG, and ultimately patient got okay. Now, we talk about acute COVID RT-PCR. As I told you, most of the patients who land up in ICU, they do have some MISC component. But there will be some patients who are just pure post-COVID MISC, RT-PCR is negative, and there are many intensive care issues related with these patients. And take my word, management of these patients is much easier than RT-PCR positive, because you have got a best tool in, you can say, which has revolutionized the whole management, that is ultrasound. This is a classical case of MISC. A 4-year-old with fever, high-grade fever for 4 days, cold extremities, look at the mucositis, look at the hypotension. Normally it is warm shock. Normally they are not fluid responsive shock. You just need to give Norepinephrine, it is diastolic blood pressure is low. If narrow pulse pressure less than one third of the systolic, you may end up in giving epinephrine. Look at the mucositis in this patient. How we evaluate these patients in intensive care? I am not talking about ward. I am not talking about in my clinic. I'm talking about ICU related issues only. So clinical, we all understand. One other than the ultrasound, one more therapy or intervention has changed the outcome. That is invasive arterial blood pressure. Normally, we put in all patients we do arterial blood pressure monitoring, especially invasive one. Echo, as I told you, it gives you lot of you can say help. It helps you in a lot of you can say parameters to find to your therapy can be based on the ultrasound and echocardiography. How it helps? It can help in like diagnosis. Look at this is your coronary artery. It is well dilated. Look at IVC. Look at the IVC. It is well dilated. Look at the contractility. So three things I need to know when I do an ultrasound. One is inferior vena cava. Is it a dilated? Is it a collapsible? Ejection fraction, and second coronaries. Coronaries at times helps in making the diagnosis if patient doesn't have classical features. This is another patient where ultrasound has helped in diagnosing pulmonary edema. This was a patient who was given fluid. This was our first patient last year, and patient was given little bit overzealous fluid therapy because we didn't knew that these patients are fluid refractory, and patient land up in pulmonary edema. Patient had hypoxemia to start with. The patient was not hypoxemic. So X-ray was not very clear in giving you an idea about pulmonary edema, but look at your ultrasound lung. This is a typical ultrasound lung which is showing a lot of B line. We call it pulmonary edema. So this is below one is the normal one. Below one is a normal and above one is abnormal, that is B line. So ultrasound is one intervention which has revolutionized the whole management of COVID related issues. Unfortunately, in acute COVID RT-PCR positive ward, we cannot take machine there. So it is limited to RT-PCR negative who land up in intensive care. Now look at this 6-year-old child who presented with fever for 5 days, loose motion for 2 days. This patient came this season. He had a shock with cardiac failure. CRP was 229, BNP was 26,000, ejection fraction was 45%. And this patient, as usual, required methylprednisolone, IVIG, epinephrine. And difference from other patient was this patient required to be in ICU for almost 9 days. Low-grade fever was persisting, right? And this BP is on epinephrine. Another point that CRP fell to normal, but after 7 days, again, there was a rise in CRP. And again, ejection fraction start dipping. So we thought of probably it may be refractory MIS. And on 7th day, we started giving second dose of IVIG, but blood culture, especially from the center line, grew E. coli. So actually, this was not a refractory MIS. This was due to your nosocomial infection. We'll talk how to chase this patient in intensive care. This is a recent patient. A month back, this child came, a 12-year-old who presented with fever for 4 days, neglected patient because for 1 day, patient was a little bit hypoxic and hypotensive, but at her home. And when patient came to us, he was in very, very bad shape. It's an altered sensorium, irritable, saturation was 92 on 10 liter. On epinephrine, 1 dose of methylprednisolone was given before the patient came to us around 6 hours back, but still patient had significant tachycardia and patient sensorium was very bad. Issues in this patient is definitely going to be the intubation, especially because patient is an altered sensorium. What you need to do, you need to reassess the preload before you intubate the patient. At times, not only they require fluid bolus, but they require good inotrope. Otherwise, patient can let up in cardiac arrest during intubation. So inotrope should be on flow. In this patient, there was persistence of tachycardia, neurological deterioration, as I told you. In fact, within next 12 hours, patient started posturing on ventilator. And there was a persistence of tachycardia even after 36 hours of starting therapy. And patient fever was persisting. It was high grade. Patient was very toxic. We thought of refractory AMIs in this patient, but what we found that CRP and other biomarkers started decreasing within 24 hours. So this type of diseases do create a lot of confusion when we deal with intensive care. If fever is persisting, CRP and procalcitonin has started dipping, but patient is very toxic. So you start thinking of giving biologic or something else. But instead of giving biologics, we thought of clearing probably we thought that IVIG and steroid is going to take time. So let's clear up the toxins. So one therapy helps in intensive care, that is renal replacement therapy with filtration. Filtration, if child age is more than say 5, 6, 7 years, where you can use auxiliary filter that is a little bit cheaper. Only one filter has to be used. So more than 30 kg, you can use auxiliary filter. And within 2 hours, these filter, whenever you do CRRT, within hour of starting therapy, patients usually become non-toxic and afebrile. So it gives you time for drugs to act like steroid and IVIG. So this patient, fortunately, despite of neurological handicap, this patient was ultimately extubated, and 7th-10th day patient was discharged, and this was a child of a doctor. So the outcome of MIS, the beauty of these patients, the outcome of MIS with COVID RT-PCR positive or without RT-PCR positive is hugely good. This was a patient who was a small baby, around 4-month-old baby, who presented with like Kawasaki with antibodies positive. This patient landed up in refractory MIS and needed your infliximab. This was the only patient who required biologics. When we talk about refractory MIS, the definition is very difficult, very not clear at all. So when we talk about refractory, so classically it is defined as persistence of fever after 2 days or reappearance after 7 days. But usual defervescence is within 24 hours starting adequate therapy, whether it is your steroid or whether IVIG. In classical Kawasaki disease, normally we wait for 36 hours after finishing of the IVIG, right? But what happens to those patients if fever persists beyond 2 days? If there is no guideline which helps us. Let's take few of the example. If fever persists after 48 hours, but patient is clinically stable and fever is settling a little bit, especially CRP and procalcitonin is decreasing more than 50%, you can wait and watch. But if inotrope score is not high, but also rising, so initial inotrope score is very high and also it's increasing. CRP is rising after therapy, like you give IVIG and steroid. Next 36 hours, next 24 hours, you find that CRP, instead of decreasing, it is increasing. You need to change the gears. What gears we'll discuss. Many of the patients may become afebrile. Your CRP may started getting settled, but they land up in significant organ dysfunction because they came late to us. So may require renal support system, cardiac support system, and respiratory support system. But friends, when we talk about recurring fever after a gap of, you can say 2 to 3 days of without fever, patient is on invasive line or respiratory support, rule out nosocomial infection, what I told you, what I showed you in my patient. What is the second line of management? Irrespective of guideline, most of the patients do just require IVIG, or you just escalate the dose of steroid. If you're giving 10 milligram, increase to 30 milligram. Very rarely you will find that drugs like anakinra, which are not easily available, or tocilizumab are being used in pediatric patients, especially if toxic shock syndrome like picture. But if there's a refractory Kawasaki like, you may end up in giving infliximab, which I showed you. They're very, very rare. Most of the time, second dose of IVIG is needed. Look at this 13-year-old female, fever for 3 days, loose motion and hypotension. She presented with the cold shock. She recovered from the shock by giving inotrope, by giving IVIG, by giving steroid, but on sixth day landed up in major seizures. Her pupil became sluggish. MRI showed typical ADM-like picture. Already on methylprednisolone high dose, IVIG, she was referred here. When she came to our intensive care, though hemodynamically little bit stable, she was having significant tachycardia. Pupils were very sluggish in reaction. And next 24 hours, what we found that there were no movement of limb and diaphragm at all. There was a symmetrical large fiber motor axonal polyneuropathy. It was different from critical care neuropathy, myopathy, was behaving like a Guillain-Barré syndrome. She was given 5 cycles of plasmapheresis and she showed wonderful improvement and ultimately she was off tracheostomy. Look at this another child who came recently, a 7-year-old with pain in abdomen for 7 days, rising liver enzyme, increasing irritability. So it looks like only abdomen is having problem. No, so see, she came last year, in around November or December. There was increase in SGOT, SGPT, there was increase in irritability, and she'll end up in refractory cardiogenic shock. Look at the blood pressure, 52/35. Look at the child, and she was hypotensive shock despite of giving epinephrine to 0.5 microgram per kg per minute and levosimendan. And this patient, within 18 hours, we need to start ECMO. And total time required for this patient for an ECMO was just 5 days. Again, the beauty of MISA is almost 100% recovery. So complete recovery is a rule unless proved otherwise, and patient was ultimately discharged. When we talk about organ support, there can be CRRT. CRRT we use very often, especially with filtration. As I told you, either it is Auxeris filter or cytosol filter if age is less than say 6 years, weight is less than 30 kg, and indication is whenever you find 10%, more than 10% fluid, positive fluid balance with toxemia, with or without renal failure. So we don't wait for renal failure, right? Now we come to ECMO. ECMO, again, rarely you will need, but you should know the indication, especially refractory cardiac failure. Normally, for respiratory reason, we don't need ECMO. Many of these patients will require respiratory support in form of non-invasive ventilation or high flow or invasive ventilation. This is our data of previous 90 patients, not last year, this year. You can view that, you can see that repeat IVIG was given in almost just not more than 7 patients. So these were actual refractory patients where just we needed IVIG. Nothing else. The patient of small baby where we gave infliximab was of last year. And inotrope was needed in 43% and respiratory support was needed in 48%. This was these were 90 patient and main age group was 7 years. This is being analyzed and going to be published. Main is the GI involvement followed by cardiac and the respiratory. Respiratory, it is the main pulmonary edema. And again, one point I want to focus is CRP. We are trying to correlate the severity of disease with the CRP and procalcitonin. Probably we are going to find a value of CRP that will, before this patient end up in refractory shock, we may be able to define, okay, these are the patients who require it, you can say a level 2 or level 3 ICU. Average stay, as I told you, outcome is a rule, is 8 days plus minus 6 days. And in the average financial burden because of IVIG is pretty high, is around 4.5 lakh. And very rarely we lose the patient. The patient which we lost, patient was discharged and developed HLH. There was a sudden increase in ferritin to 50,000. This was the only patient we lost. Now, regarding differential diagnosis, when this patient in intensive care, rest of we are going to discuss in MIS. 2 points I want to make. One is SLE, one should keep in mind. Second is the pancreatitis, especially if there's abdominal catastrophe and appendicitis. The DK, appendicitis, pancreatitis should not be forgotten. when we are making differential diagnosis, you land up in critical disease. And the very important differential diagnosis is hemophagocytic lymphohistiocytosis. You can say MIAC is a sort of HLH, but it's a difference is there. There's an increase in ferritin, there's an increase in liver enzyme and cytopenia, and these patients, take my word, require long and prolonged steroid therapy. High risk feature for a clinician. If any patient with refractory shock, we all know that it belongs to high risk feature. But if you find CRP, especially more than 150 to 200, procalcitonin more than 5, even before they land up in major problem, they indicates this patient is going to land up in major problem. And again, very high ferritin, more than 1000 to 2000, that indicates a component of HLH. These require more steroid, high dose steroid, and prolonged steroid. A patient who is suffering from severe pain in abdomen, believe me, these are the patients should not be admitted in a small nursing home, should be referred to a patient hospital where there is a good ICU. So conclude my presentation with some take-home messages. Of course, early recognition not only saves mortality, but also saves morbidity. Overdiagnosis and misuse of IVIG and steroid are going to happen. Be careful before you start steroids, especially. Steroids only, people ask, probably MISC person is going to discuss about that. Pancreatitis with MISC and DKA, you try to avoid steroid, and you need good prospective studies to define our queries, which are specifically Indian queries. And now we are going to have a lot of diseases like dengue and scrub typhus. So beware of these diagnoses. Just don't jump to the conclusion of MISC. Thank you very much. Thank you.
Thank you, Dr. Dhiran. Very nice way of presenting the different case scenarios in the PICU. Now, very shortly, 5-7 questions are there. I think the panelists will be answering. The first question to Winsley Rose. Are you there, Winsley Rose?